This topic, I suppose, is important both for the sake of practical understanding and with respect to outcome of the patients post-operatively, because fluid and electrolyte balance is one of the key factors which holds responsibility for determining patient outcome after the surgery. So to begin with, I would like to start with this the fluid component, the components of the body. And I'm sure that most of us would have gone through pictures similar to this, where various compartments of the fluids are described. Fluid basically constitutes approximately 60% of the human body weight. And out of these 60%, there are two basic compartments of the fluid in human body. One is the intracellular and extracellular. The intracellular is a larger compartment comprising two-thirds of the fluid mass. Regarding the extracellular compartment, and there are further two classifications, two compartments within this extracellular part, the interstitial and the plasma, the intravascular space. Now, this interstitial compartment is nothing but the interstitial space, that is the space which is present in between the cells where the fluid is present, and the other one is the intravascular compartment. Now, interstitial compartment has got a very important reservoir function because it is basically in close communication with the intravascular space or compartment. And whenever this intravascular space swells or the intravascular pressure rises, fluid comes out of the plasma or the intravascular space into the interstitial part. And vice versa, when there is condition of hypovolemia, when intravascular space shrinks, fluid moves out from the interstitial compartment into the intravascular space. Now, hence it is very easier to understand that whenever we infuse too much of fluid during the perioperative period, fluid moves out from the intravascular space into the interstitial space, giving rise to the subcutaneous edema, which is very commonly seen. And another important reservoir function of the interstitial compartment is the fact that all the proteins which are all the proteins which are released by the cells are primarily released first into the interstitial compartment before they are being channelized into the plasma via lymphatic channel. And now, this third space is also proposed to be another component of this extracellular compartment. And recently, a big question mark has been raised onto the existence of this third space. We shall talk about it somewhat later on. And what exactly this third space is, it is basically a hypothetical space, and it is said to be formed by fluid accumulating as a result of transudation of fluid from traumatized or inflamed cells. And the common examples are like fluid collected within the GI in the GI tract, or the ascites, or in the pleural effusion. So we'll discuss some more facts regarding this. And this chart here shows the age-wise distribution of fluid between various compartments. And fluid compartment basically shrinks as one ages. And this shrinkage in the fluid compartment is primarily because of the shrinking, as you can see, shrinking of the fluid in the extracellular compartment from roughly 30 to 40% at the time of birth to around 20% at the time of adulthood. The intracellular compartment, as you can see, remains almost constant. And this shrinkage is because of the interstitial space getting shrinked as one moves towards the old age. So coming on to the intraoperative fluid therapy. So what are the basic aims? Basic aims are primarily two. One is maintain tissue perfusion, or you can say organ perfusion. And another is electrolyte. balance maintenance. The components of fluid therapy, which we usually traditionally describe, are the compensatory vascular expansion, then deficit and maintenance fluid, and then replacement of losses in the form of third space or blood loss. Then, first of all, compensatory vascular expansion. It is the fluid volume given to compensate for the vasodilation which occurs during the induction of general anesthesia. And it is to the tune of 5 to 7 mils per kg and should be replaced during induction. Now, the deficit which we usually give during any anesthetic intervention during any surgical procedure includes preoperative fluid deficit due to fasting, because before any surgical procedure there is a period of fasting and person is not drinking any fluid. So it is presumed it is it has to be taken into consideration that period, and it is calculated similar to the maintenance fluid on hourly basis. The maintenance fluid is for insensible and the urinary losses. So both are calculated by the 4 to 1 rule, based on the calorie consumption method. And 4 to 1 means 4 mils per kg per hour for the first 10 kg. Then 2 means 2 mils per kg per hour for the next 10 kg. And thereafter 1 mils per kg per hour for additional body weight. Now, one will be the maintenance. It will be given on hourly basis, and whatever deficit comes on, 50% is replaced in the first hour, and the 25% each in second and third hour. So regarding the choice of fluid, we can't interact much, but I prefer to interact in the next few slides. But what should we prefer, whether we should prefer dextrose or non-dextrose containing fluid? We should not use dextrose containing fluids, because surgical stress decreases insulin release owing to increased levels of catecholamines, cortisol, and growth hormone, leading to hyperglycemia. And the fluid used for volume maintenance should not contain dextrose. It should be dextrose free, because otherwise the stress response on one side is causing hyperglycemia, and we also pushing dextrose fluid, so blood sugar levels will be high, which we don't want. Now, coming on to the losses can be primarily of two types: the third space and the blood loss. Third space losses are proposed to be based on the invasiveness of the surgery. The more invasive the surgery is, the more higher third space loss is presumed to be. For example, minimally invasive surgeries like small, herniorrhaphy, 0 to 2 mils per kg per hour. And moderate surgeries like open cholecystectomy, one should go for 2 to 4 mils per kg per hour. And major surgery like bowel resection or radical cholecystectomy, Whipple's procedure, something like that, one should go for 4 to 6 mils per kg per hour. However, recently there has been quite a lot of objection in terms of replacing this amount of third space loss, and various articles say that insensible losses are highly overestimated, and maximal insensible and evaporative losses during a major abdominal surgery is 1 mils per kg per hour. Now, this is one of the articles which questions the existence of third space. I will share few facts which this article has discussed or shared. And it proposes that classical third spaces are more of a fiction, and perioperative fluid shifting predominantly represents fluid movement into the interstitial space. It is not moving basically anywhere like any space in like third space, but it is going into the interstitial space, as we have been discussing in the first few slides. This fluid shifting can be of two types, namely type 1 is physiological, when protein free fluid is coming into the interstitial space from the intravascular compartment. And type 2 is pathological, where protein rich fluid shift occurs, and it happens whenever there is damage to vascular endothelial glycocalyx, and it is commonly seen in conditions of trauma and sepsis, But another condition which may give rise to this condition is hypervolemia, which we might give rise to during any surgical procedure via inadvertent fluid therapy. Now coming on to the blood loss. Blood loss is should be replaced till a maximum allowable blood loss limit uh, by either crystalloid or colloid in a crystalloid in a ratio of 3 is to 1 and colloid in a ratio of 1 is to 1. This is the formula by which we calculate MABL, we usually call for individual patients. And if we are using, for example, a patient crosses this limit of maximum allowable blood loss, then like if we are using PRBC, how much volume should be used depends on the hematocrit of the substitute which we are using. For example, for PRBC, we consider hematocrit to be to the tune of 60. Now, let us quickly go through a case scenario which I have formulated based on the concepts which I have discussed just now. Let us consider this 48-year-old female who underwent exploratory laparotomy. Her hemoglobin is 12 grams and body weight is 60 kg. 5 hours duration of surgery and period of fasting 9 hours, no medical risk factors, and blood loss occurred 500 mils over the last 2 years. So it is really helpful that if one maintains this kind of a chart, especially for long duration of surgeries like 5 hours, 6 hour surgery. And I have done few basic calculations like maintenance fluid of 100 mils per hour, then fasting deficit was 900 mils and MABL was 1.75. So our patient underwent 500 mils of fluid loss in the last 2 hours. So we don't need any blood in this case. So initially at the time of induction, compensatory vascular expansion we did of 300 mils crystalloid. Then in the initial 3 hours, we replaced the fasting, continued with our maintenance, and then we also started third space losses replacement. In the last 2 hours, we replaced blood losses with colloid in a 1 is to 1 ratio. So to conclude, we gave 3.2 liters over a duration of 5 hours, you can see. And important thing is that out of this 3 liter, 1 liter was third space replacement and 1 liter was fasting. So nearly 60% was these two components and remaining 40% was maintenance. So one should be careful whether well, there are two facts and this is how you are going to tell an exam because this is the strategy which is described. But if we look at the clinical scenario, we should always consider that how much third space loss we are replacing. Now, coming on to the intravenous fluids, there are primarily crystalloid and colloid and their long-standing battle. And then we have the option of balanced salt solution both for crystalloid and colloids. Crystalloid solutions are the solution of inorganic ions and small organic molecules dissolved in water. And these are the commonly used crystalloid solutions perioperatively. And dextrose and ringer are hypoosmolar as compared to plasma. And saline and DNS are hyperosmolar. Now this chart over here shows the fluid distribution, say after half an hour or 1 hour infusion of 100 mils of the fluid. And usually with saline and ringer, approximately 30 mils remain in the vascular space. And the remaining 70 to 80 mils goes into the interstitial fluid compartment. Well, with 5% dextrose, however, only 10 mils approximately remains in the plasma and remaining 70 mils, not remaining 70 mil, but 70% approximately goes into the intracellular space. So this is particularly important. We should avoid using 5% dextrose as the perioperative fluid therapy. Instead, go for DNS, which is a better option. And especially this kind of fluid should be avoided in cases of brain surgery where this may give rise to brain edema. Now, I personally like balanced salt solutions very much, and balance is basically essence of the life. And these two individuals are trying to maintain the balance, but somehow this job is very difficult, and some wrong events may happen. And this is kind of a something mishappening which has occurred recently. And there are two kinds of thoughts which are prevailing, like they have done it knowingly, or it happens by chance. Well, one should be very much cautious when one is trying to maintain balance. And going for the concept of this balanced salt solution, these are described as solutions with with different electrolyte compositions close to plasma, and with strong ion difference of 24 milliclins per liter. And I totally agree that this definition is somewhat complicated to understand. So I have dedicated 4 or 5 slides that what is the basic concept of this balanced salt solution, and why one should basically use balanced salt solution, especially in a long duration surgery. So these are the key factors which affect the acid-base behavior of plasma. One is the strong ion difference, then non-volatile weak acid concentration, and PCO2. PCO2 level is irrelevant as far as fluid infusion is concerned. So we shall be discussing primarily SID, that is a strong ion difference, and weak acid concentration. Well, SID is something the difference of strong cations and strong anions, and it is to the tune of approximately 40 milliclins per liter. And the key weak acids which are of importance as far as acid-base behavior is concerned are the albumin and the phosphate. So what happens with changes in SID? Because whenever we are going to give any fluid, definitely it's the body's SID is going to change because of the electrolytes which we are going to infuse. So how does it affects the pH of the body? So whenever SID increases, there occurs metabolic alkalosis, and whenever SID decreases, there occurs metabolic acidosis. And vice versa, with acids, whenever acids decrease, there occurs metabolic alkalosis, and with increase in acid, metabolic acidosis. So how these changes are important, how these changes are going to affect the body's pH whenever we are going to infuse any fluid? So most of the crystalloids, if we look at, they don't have any weak acid with them. So ATOT is 0, and strong ion difference of any crystalloid will depend upon its electrolyte composition. So let us consider saline. Saline, the strong ion difference is 0, and ATOT obviously is 0. So whenever saline is infused, the body's SID decreases, and weak acid concentration also decreases. But the decrease in SID is much more in comparison to decrease in weak acid concentration. As a result, when we infuse large amounts of saline, especially after long duration of surgeries, there occurs metabolic acidosis, which we commonly see after long duration surgeries. So, how the balanced salt solutions are going to answer help us in this kind of situation? If we consider saline as a base from which balanced salt solution is being prepared, then simply it has been found that if 24 milliclins of chloride are replaced with 24 milliclins of bicarbonate or bicarbonate substitutes like lactate, acetate, gluconate, or malate, the decrease in SID which this balanced salt solution is going to make balances the decrease in weak acid concentration. So it kind of produces a balanced job between these two, prime factors which are going to determine. So in a nutshell, it will affect the pH to a very minimal extent. Along with that, what has been done, that a few other electrolytes have been added, so that whatever the composition of the plasma is, it parallels that composition, so that the electrolyte composition holistically of the plasma doesn't changes much. So if we look at the choice of the buffer, it is lactate. We have seen ringer lactate, which is available with us, but the side effect associated with it is that it causes hyperglycemia due to gluconeogenesis. Then another buffer which is commonly used in balanced salt solutions is the acetate, and it is very metabolized very rapidly and provides immediate buffering. Then malate is also there, and it is metabolized very slowly and provides a long duration of buffering effect. So different crystalloid solutions, balanced salt solutions have got different buffers, as you can see: acetate, gluconate, and malate. Now, coming on to colloid solutions. Well, these are large molecule solution of large molecules of non-crystalline substance dispersed in water. And the commonly used colloid solutions are gelatins, dextrins, hydroxyethyl starch, and albumin. The gelatins are prepared by hydrolysis of bovine collagen, and the commonly the brands which are available are the gelofuscin, which is 4% succinylated gelatin, and Himaxal 3.5% polygelatin. And hypersensitivity reactions are said to be very commonly associated with gelatins, but the incidence is pretty low, less than 1%. Then dextrins, these are synthesized from sucrose, and it consists of D-glucose polymers linked by alpha-1,6 bonds into linear macromolecules, defined by their weight averaged molecular weight. And there are two variants which are commonly available: dextrin 40 and dextrin 70. Dextrin 40 improves microcirculation, and this improvement is because of increase in plasma volume. So it provides a sludging effect to the RBCs and the platelets. So thromboid forms. Now, coming on to the hydroxyethyl starch, it is synthesized from amylopectin, which is a D-glucose polymer derived from maize, and hydroxyethyl substitutions occur at C2, C3, C6 positions of glucose. And the higher degree of substitution of these hydroxyethyl residues is there, slower will be the metabolism. And based on the molecular weight and degree of substitution, these are classified into three categories: high, medium, and low. High category I haven't seen. In the initial period of my training, I have seen this medium molecular weight hydroxyethyl starch, which used to came in with the name of Hesse-Sterol. The molecular weight was 200 and degree of substitution 0.5, and their dose was in the range of 20 to 30. But recently we are using lower molecular weight variants with lower degree of substitution, which increases their metabolism. And these are the tetrastarches, and common brands so that you can get familiar are the Tetraspan, Volulite, and Voluven. Regarding side effects, one of the important side effects is the impaired hemostasis, and it results from the hemodialysis giving rise to impaired platelet aggregation. And this impairment in the hemostasis is directly proportional to the degree of plasma volume expansion. Finally, albumin, there are two variants, namely 5% and 20%. 5% variant is used when crystalloids fail to sustain plasma volume. And this 20% variant is not used for volume resuscitation. It is primarily used more in the ICU setup when it is presumed that there is interstitial edema and one wishes to draw the fluid out of that interstitial compartment. And definitely it should not be used in cases of hypotension. Now, finally coming on to the controversies. Are the colloids safe, and how much fluid one should use in the perioperatively? So, whenever this kind of situation arises, one looks for the evidence, and really, evidence is not easy to define or to understand in such kind of scenarios. So, these are the two trials which questioned the use of colloids perioperatively and said that colloid is bad, it should not be used. Well, the chest trial said that in patients in the ICU, there was no significant difference in 90-day mortality between patients resuscitated with 6% Hess or saline. However, more patients who received resuscitation with Hess were treated with renal replacement therapy, where the similar results were shared by the success trial, which showed that patients with severe sepsis assigned to fluid resuscitation with Hess had an increased risk of death at day 90 and were more likely to require renal replacement therapy. So, in both these cases, the study subjects were ICU patients in whom the vascular endothelial was already compromised, and in those cases, they have used colloids. So, few important facts which one should consider before adopting the recommendations of these two trials is that colloid only behaves like a colloid when the vascular endothelium is intact and patient is in need of intravascular expansion, that is hypovolemic. So with the endothelium intact and patient being hypovolemic, this is the right choice of patient where one should consider use of colloids. And benefit of a colloid in the setting of an intact glycocalyx in the patient undergoing volume optimization during major surgery or after major hemorrhage may be very different from the risk of Hess, which has been told by the previous two trials during the its use in patients of sepsis. So, colloid is safe to use in hypovolemia without endothelial damage. And this RCT compared the use of boluses of crystalloid or colloid for goal-directed fluid therapy during major surgery, and no difference was found in outcomes. However, 60% more fluid was needed in the crystalloid group. So in clinical practice, it has been seen that if there is no hypovolemia and if only crystalloid is used and the crystalloid plus colloid is used, the ratio appears to be approximately 1 is to 1.5. And this ratio rises when hypovolemia is present. That is, if in the setting of hypovolemia, uh, crystalloid are required in a much more higher ratio. So, coming on to the second fact, how much fluid should be used? And in the literature, these are the three fluid regimens which are commonly being used: the liberal, restrictive, and the zero balance. And various definitions have been described, and I have mentioned fluid values defining these therapies which have been used most commonly. So, and before coming on to individual fluid therapy, most of us want to be in this zone, but it is really difficult uh, to assess or to guide oneself in this zone. And why one wants to be in this zone? Because if one is in the hypovolemic part, then there occurs organ dysfunction because of poor perfusion of the organ. And if one is in this zone, then definitely there is prolonged bowel recovery owing to bowel edema, and their patient overweight is there. So these kind of things will be associated. So first of all, regarding the liberal fluid therapy, this is a standard fluid therapy with replacement of third space fluid loss as we usually do, and fluids are usually given more than 3 liters per day. And excess fluid administration leads to vascular endothelial damage and increased leak of fluid into the interstitium. And these patients are associated with weight gain, bowel edema and delayed recovery, and extended hospital stay because they require more time to for the settling down of the edema and the interstitial fluid which has been accumulated to come into the intravascular space, and thereafter they can return to their normal routine. So avoid excess fluids. This is what the events which are associated with liberal fluid therapy are associated. Then zero balance fluid therapy, background infusion of a balanced crystalloid at 2 to 3 mL per kg per hour. Very useful for many surgical procedures, and if there is a major surgery, then major surgery, the goal-directed fluid therapy is advised. What is goal-directed fluid therapy? We talk often about it, and it is defined as fluid therapy guided by hemodynamic measures of fluid responsiveness. And boluses are given if hemodynamic measures of fluid responsiveness indicate, and hemodynamic measures used are the dynamic variables in the form of stroke volume variation and pulse pressure variation. So whenever these parameters, their values goes beyond 13%, it is an indication of fluid bolus, and at that point fluid bolus is given. And why these measures are used? Because their value varies during inspiration and expiratory phases of respiratory cycle. And if a patient is volume depleted, this variation increases. And hence these dynamic variables are found to be more accurate than CVP. So people have started now to rely less on CVP and more on these parameters. So what are the basic benefits of GDFT, goal-directed fluid therapy? Better hemodynamic stability, decrease in serum lactate at the end of surgery, and lower incidence of post-operative complications. And one very frequent term which is nowadays being talked upon is the ERAS, or enhanced recovery out of after surgery. And this program helps to minimize the stress response to surgery and accelerates recovery after surgery. And in a nutshell, basically the basic component of ERAS is that patient should be brought to the OT in a fed state, and during the surgery, this goal-directed fluid therapy is used, and in the post-operative period, oral route fluids are started as early as possible. So this is the basic chunk of ERAS protocol. And what has been observed that patients following ERAS are more likely to be euvolemic upon arrival to the OR. Hence, we don't need to give them the common replacements which we usually give, like replacement of fasting and all, and third space losses during the perioperative period. So it has been found to reduce the hospital stay for colorectal surgery by approximately 2.5 days, and it decreases perioperative complications by 50%. So this is what I have been talking about, the various components of ERAS in colorectal surgery in the various perioperative phases. So one often looks for the evidence whenever trying to define an algorithm for perioperative fluid therapy, but it's not easy to define the things holistically. And a few years back, I was happy with this article which has suggested an algorithm like how one should plan perioperative fluid therapy. But subsequently, in the years to come, these two articles came, and this article published in NEJM in 18, commonly called as a relief trial. I don't know, after adopting this kind of suggestion, whether we will get relief in the perioperative period, similar to this guy who seems to be so much relieved. Fine. So a crystalloid infusion rate of uh, this article suggests that a crystalloid infusion rate of 1 mL per kg per hour as maintenance for most of the surgical procedures, along with the fluid boluses based on hemodynamic parameters as guided by GDFT. This relief trial suggests that among patients at increased risk for complications during major abdominal surgery, a restrictive fluid regimen was not associated with a higher rate of disability-free survival than a liberal fluid regimen, and was associated with a higher rate of acute kidney injury. Often I find it amusing, but the conclusion lines are written in such a complicated manner that one has to go through them repeatedly. So that's why I put interruptions in between this continuous line, because what it suggests simply that no obvious benefits of restrictive fluid regimen are there over liberal. However, it is associated with a higher rate of acute kidney injury. So what does it suggest? So to give something more simpler, the Miller suggests that goal of fluid management for major surgery should be a moderately liberal approach, neither restrictive nor liberal, somewhere in between. So the components should be like average crystalloid infusion at a rate of 10 to 12 mils per kg per hour during surgery, along with 1.5 mils per kg per hour in the post-operative period. Then at the end of surgery, positive fluid balance to the tune of 1 to 2 liters. One should avoid more than this. And for example, 3 liters for a 3 to 4 hour procedure, to 1 to 2 liter crystalloid for a less extensive surgery with minimal blood loss. So to conclude, crystalloids only for a replacement of deficits and maintenance, colloids only for blood loss. Third space replacement should be done very carefully. Fluid infusion also causes metabolic acidosis, and balanced salt solutions should be used in long duration surgery. So preoperatively encourage drinking clear fluids until 2 hours before surgery. Intraoperatively, all patients should have a fluid and hemodynamic management plan. Aim for 1 to 2 liters positive in major surgery. Maintenance crystalloid or colloid for fluid boluses. Then optimize volume first, then add vasopressors as needed. Use goal-directed therapy for moderate to high-risk patients. Then post-operatively, so here one may see that they have given GDFT for moderate to high-risk patients. So we may stop using CVP as a practice, as a guide to fluid therapy. Then in post-operatively, early transition from IV to oral fluid therapy, remove IV lines as soon as possible. Thank you very much.